Hello, welcome.
Hello. No way.
Okay. Hi, everyone. Thanks for joining. Tonight, we're going to have our SPH live talk on EpiPens and peace of mind. And just a little shout out to SPH Medical. They're here to help all the community for all their medical needs and any referrals they need. So we're excited to share with you a little bit about um, allergies. And if you have any questions, you could tune in at the end and ask Dr. Samstein your questions. We're just going to start by introducing ourselves. I'm Jennifer Maleh Mizrahi. I'm a fourth-year medical student, currently applying for a pediatric residency. So fingers crossed, we'll see where we end up. And I had the honor of meeting Dr. Miriam Samstein. She graduated from Cornell with a MD and a PhD, very impressive, and then stayed on for residency at Cornell and for her allergy and immunology fellowship. So without further ado, if you could just tell us a little bit about yourself.
Hi, everyone. As the beautiful introduction said, my name is Miriam, and I did my training at Cornell, where I also did my pediatric residency, and then I went to Long Island Jewish, where I did my allergy and immunology fellowship. Most allergy immunologists are trained to see both adults and children, but and I am boarded for both, but the job that I took afterwards is pretty exclusively pediatric. So I see patients up to generally age 24 for a variety of both allergic and immunologic conditions. So that would include food allergy, which is the most popular, hives, or interesting skin rashes, medication allergy, so things like allergy to amoxicillin, environmental allergy, things like being allergic to pollens or cats or dogs, and as well as like immune disorders or immune deficiency, and a little smattering of eczema too, but I share that with the dermatologists.
Very, very cool. So different people mean different things when they say the word allergy. So can you tell us what does that mean to you and what does the word allergy really mean?
Yeah, this is a really great question because sometimes a patient will trek all the way out to my office after having waited 3 months for an appointment to find out that they're at the wrong doctor. And so when I use the word allergy, I'm referring to something very, very specific. I'm talking about a specific immune response that happens in your body. It involves special allergy cells called mast cells. And generally, you encounter your allergen, and within a couple of hours, but sometimes even immediately, those mast cells have a big response and they cause you to have symptoms like hives, vomiting, diarrhea, even fainting, wheezing, passing out, or anaphylaxis in a very short time frame after meeting your allergen. If you're not exposed to the allergen, you should not have it. So you shouldn't be having like constant symptoms unless you're constantly exposed to your allergen. That is very different from, for instance, someone who is afraid that they have celiac disease. That is a real bad reaction that you can have to food, but that is a gastrointestinal reaction. So that is actually seen by the gastroenterologist. Or people who have various sensitivities. The most easiest one to think about is lactose intolerance, where you'll eat dairy and you might have like gas or bloating, but it's not really a life-threatening thing. But it's a real thing and is really uncomfortable and or embarrassing. And you can actually have such a thing to like various foods, not just lactose. And again, allergy testing will be negative even though you actually have this thing. So it's not that you don't have a problem with that food, it's that you're at the wrong doctor for it.
So when somebody does have an allergy or reaction like you're talking about, what would be the different branches of allergies? What are the different groups that you would say, okay, that is an allergy?
Yeah, so allergy that belongs to an allergist actually has 4 categories. The one for food generally is what we call a type 1 allergy. So, and you can have that to other things too. So environmental allergy, for instance, also and some drug allergies. You encounter your item and the symptoms that you'll have are generally very time specific. So you're not wondering what the trigger was unless you had like 7 foods at that meal, but you're associating it with something. And you're saying, okay, you know, within that encounter with that dog who licked me, I suddenly had hives all over my body, or I ate this peanut and then I started having vomiting within 30 minutes. I started having wheezing, I passed out, I was blue around the face, etc. Which is very different from the other kinds of allergy, like delayed reactions or something like that. With the caveat, just in case there are some parents on here or some teachers who might have a kid with this, in very small infants, there's a special allergy that I see. It's a special disorder which works completely differently. It's much more newer discovered. It's called Epi-Pens, or food protein induced enterocolitis. This is you eat the food and then usually several hours later you have extreme vomiting. Like, people will probably think you have an infection or something like that because of how horrible it is. You can literally vomit to the point of dehydrating yourself to where we can't even find a vein to put an IV in it. You can also have a lot of diarrhea at the same time, and the children are extremely lethargic when this happens. It's more common in infants or young people, but occasionally adults can have it too. Generally, for most foods, you'll outgrow it. So that is a special one that I also see that's different. But if someone comes in and they're very non-specific, like, oh yeah, every now and then I have this, but there's no like association time with a trigger, it's probably not an allergy, because you should have it within a very specific time frame. So often the parents can like identify what the likely trigger is before anybody else, because they know every time they give their kid this food, it's happening. Or every time they go visit their aunt with the cat, their kid has like extremely swollen eyes, within a half an hour. It's pretty obvious.
Oh, that makes sense. So let's say I have a kid or myself or someone that I know feels like they have an allergy and they come to your office. What would be sort of the next steps? Like, how would you encapsulate the next steps?
Yeah, so kids like to see me because I tell them I'm a big talking doctor. There's not going to be a ton of needles. So first we have to do like a really nice conversation with each other where the parent describes to me the different things that they've seen, and what was going on right at that time. Was the kid sick? Were they not? Were they eating? Were they outside playing? What were the exposures? And then based on that, we decide together if we're going to do testing and what we're going to do testing for. There's two kinds of allergy testing that you can do. One is a scratching test. I think that's the one that people are more familiar with. So that's where I have extracts from various allergens. And I will scratch either, if it's a little child, their back, or if it's a more grown up, the inside of their arm. And it sits there for 15 minutes, and then we come and we measure what you made hives to or not. Very important, if you are desirous of that kind of testing, you can't take an antihistamine, which is something like Benadryl, Allegra, Claritin, Zyrtec, etc., 4 to 5 days before you come see me. Obviously, if you need to take the medication for medical reasons, by all means, take it, but don't then be disappointed that we have to wait before we can do that test. The other form of testing is a blood test. That is exactly what it sounds like. We take some blood, we send it to a laboratory, and then they spit us out some numbers, and then based on those numbers, I'll interpret them and we'll decide together what we likely think is going on. If the numbers look allergic, we're going to avoid, we're going to talk about how to do, etc. If the numbers look great, I'd be like, great, you're not allergic, eat the food. But there is a gray area. People hate the gray area, but that's okay. That's what I'm here for. So if there's a gray area and we're not sure, we don't just avoid, like we don't just take it away, and I don't just send someone at home to be terrified to do this with their child, to feed it at home. I bring them in for a specialized test called an allergy food challenge. So they bring in the food in question. I feed it to the child over 45 minutes or so to an hour. Then I watch them for an additional 2 hours. Again, you should have your symptoms within that time frame. If you're truly allergic, you shouldn't wake up the next morning with symptoms. So it's a lengthy visit, but it's enough time to really get to the bottom of it. And that is considered what we call the gold standard. If you eat it in front of me and you're fine, you're not allergic. I don't care what the blood says. I don't care what the scratch says. Like, we're done. You're great.
Okay. And can you just go in a little bit? I know you said sometimes this can be confusing, but the difference between the challenge test and an exposure therapy.
Yeah, so the challenge test has one purpose, and that purpose is, are you allergic or not? So we are really trying to get the person undergoing the test to eat a full dose of that food in one sitting. Now, a full dose for you is going to be different than a full dose for a 1-year-old, right? Because you're going to eat different amounts of the food. So we have to weigh it out and give that much. But the point is, it's a lot of food, right?
Mm-hmm.
It's a lot of, you're not eating a speck. And then if you make it through, you are not allergic and we are done. And if you don't, if you have symptoms, I will treat you. I will not send you home until you're better. But again, we've all seen it. We're all convinced we know you're allergic. Exposure therapy is something different. And I love the way you said therapy, because it's not a cure. A lot of people have been throwing it out there. It's gotten a lot of press and people are really excited that there's a cure for their food allergy. There is not. I am so sorry to have to break the news to anyone hoping for it. It is a beautiful treatment, but it is a treatment. So that is when we slowly teach the body to tolerate certain amounts of the food. So it involves a food challenge, many food challenges, but the difference is, if you're coming to me for a regular food challenge to determine if you're allergic or not, you're probably eating like a full 2 tablespoons of peanut butter. When we're doing a food challenge, for exposure therapy, we're starting very low to the point where I probably can't even use peanut butter. We have to use like a powder so that we can out. And then we do that same, 3-hour process for that amount. Then you eat that every single day at home. You cannot not eat it. You can't skip.
Okay.
So every day at home, and then you come back 2 weeks later, and we do the same process again with a little bit more, and we keep
Wow.
doing with the patient eating at home in the middle until we get up to what we consider a therapeutic dose. They have to keep eating that dose every single day. Sometimes you let them skip a day when they're like, 6 months to a year in, but in general, they have to eat that food very consistently. Otherwise, they could lose their tolerance. They're not supposed to eat more than that food. So you can't just like go to a buffet and load up on like all of your allergens without knowing what you're getting. That could end badly. And they're still supposed to carry their Epi-Pens, because if it does, they need to be able to treat themselves. And you also have to have a really close relationship with your allergist, because there are certain things that can lower your tolerance to the food, even though you've been eating it every day. So if you're sick, for instance, you might have to go down in your dose, or if you're starting different medications, etc. So it is what we call a treatment, and it really does a great thing for children. Like, for instance, if they're allergic to dairy and they go to a party and there's a pizza, like we could get them up to eating a pizza,
Wow.
but it's not so that they can just go to the ice cream parlor and like freely eat whatever they want, which some people treat it as that, and then we end up in a bad situation. So that is kind of the difference there. One is a treatment and one is actually just a test.
Okay, that makes sense, a lot of sense. So, speaking of that kind of treatment, what are the other types of treatments? I know there's different groups. I know there's different types. So, if you could walk us through the different treatments and maybe show us some tutorials on how to use
Yeah.
them, that'd be great.
So for food allergy specifically, the major treatment is avoidance, right? You're not supposed to eat your food. I would say most people logging on to this talk have a step ahead of other people that I see, because you're used to reading labels, because you're always looking for your kosher symbol and what's in there. So for instance, my kosher keeping patients do not tend to have as many slip ups with an allergen like dairy. And or if they're going out to a restaurant and they're at a meat restaurant, like they're going to be fine. But a lot of my other patients have a lot of accidental reactions. So there's avoidance. But then obviously accidents happen, right? Especially with children, and what do we do about that? So when you go to your allergist, before you leave the office, you should have made a plan with them. Sometimes we even give a printed document that's called the Emergency Food Allergy Action Plan. What do you do when you have an accidental ingestion? The first thing is, if you notice the kid ate something and they're completely fine and nothing else is happening, like, okay, do nothing, just watch them, and please then inform us, because it's going to tell us something, like maybe they outgrew it, maybe they're tolerating something else, right? But if we have symptoms, then, and for each person it's different, so it's an individualized plan that you have to talk with your allergist about. But by and large, for mild symptoms, which would be things like maybe just a little bit of rash or some sniffles, etc., for most patients, they're then just going to take an antihistamine. A lot of people know about Benadryl. That's actually not my favorite. Benadryl has a lot of side effects for kids. It's very short acting, like it only lasts for a few hours. So I actually like, if you have it around, Zyrtec, or the generic name is cetirizine. It tends to last longer and be less sedating, which means it doesn't knock the kids out or give them hyperactivity either, so less brain side effects for them. But obviously, if all you have is the Benadryl, give that. The other antihistamines like Allegra or Claritin are not really potent enough, so you can give it, but like please get something else while you're waiting. But what if we have a severe reaction? So that would be like the kid is having a breathing trouble, right? Or they're having two systems. So they're having hives and they're having vomiting, or their entire body is covered in hives. They're really uncomfortable, or they're just vomiting. They're not stopping, right? So like there's a lot of different ways you can have severe symptoms. We go through them all in the office, but they're having that. This is the one that people have heard about. This is the one that a lot of, for instance, not just parents, but also teachers, right? In a school will have heard about, or if your kid doesn't have an allergy, but the kid coming over for a play date does, and the mother's like, oh, and there's an Epi-Pen in the back in case you need it. And you're like, what? Yeah, that definitely happens. So That is the emergency medication. It is basically epinephrine, and it comes in a lot of different forms. So I have a few here to show you. Give me a second. Let me get that. So there's a lot of different forms of it. Inside of them are all the exact same medications, okay? So if you're in my office and you're having a food challenge, you have a reaction, I'm not even going to use any of these fancy things. I have an allergy nurse. She has a bottle and a needle, and she's going to draw it out because that's when she's a
It's
nurse.
the same thing.
Obviously, we are not expecting parents to do that at home, even though insurance companies would love us to, because that is not fair to anybody whatsoever. So instead, we have these nifty little devices that is packaged into to make it easier for you. There are hundreds of these. So I'm just going to show you some of the more common ones because each company then started to make their own like generic. And again, the medication is exactly the same, so they'll all work fine. Mm-hmm. It's just about the delivery. Okay. So they're going to come in these little tubes like this, and then you pop them out of the tube, and then it looks like this, and you have to pull, and the colors are different based on if it's for a child or an adult. So that's why this is yellow, it's for an adult. And then you have to take off these blue caps and press it to the end of the thigh. The thing to know about these, especially for children, is that at the end the needle is exposed, which is why it's not my favorite, but again, sometimes it's all that insurance will cover. So if you have a squirmy kid who just got a shot, right, from their parent, and you're left holding a needle, you have to be really careful so that none of you get like stuck. So there are those, and I warn everybody about that. The more common one that a lot of people are used to is the first one that we used to have in the market. It's this guy. This is a regular Epi-Pen from a company called Maleh. And it has a little rhyme that comes with it. Blue to the sky, orange to the thigh. So you pop off the blue, whoosh, and then you take the orange one and you press it. I'm going to stand up so you're going to have to see my face for a second, to the outer aspect of the thigh until you hear a click. Okay. There's no needle. Don't worry. I didn't just inject myself. You count it. 1, 2, 3, and then you're done. And you see this came down, so the needle retracts. And these are trainers so you can practice at home. And this is a fun one if you haven't seen it before. If you speak English, this is pretty foolproof. If you don't speak English, you better make sure that that person knows how to use it in advance because you're expecting it to talk to them and they don't know what it's saying. So it says pull out. You just have to follow this arrow. Just take it out of the box and then listen what it's going to do.
This trainer contains no needle or drugs and is for training purposes only. Do not use this trainer during an allergic emergency. If you are ready to use, pull red safety guard down and off of this trainer. Place black end against outer thigh. Then firmly until you
2 seconds and then you're done.
Training complete.
So a lot of people like this one.
This trainer may be reused for training.
Other people that like this one is teenagers because this goes real nice into a jeans pocket or a purse. So college kids who refuse to carry their medications will sometimes carry this.
It looks cool. It looks very trendy.
So people generally like this one too. The devices that I showed you, they're all injections, and they all these two come in 2 doses, adult and child. This one comes in 3 doses, so it also has a baby one. So also a lot of times we like it if the child is very small because we get just a tiny bit smaller of a dose. But again, if we can't get it and we can get this one, it's no problem. It's okay to have a little bit higher of a dose. The medication itself is not dangerous. You go to the hospital after you inject yourself because the reaction can come back. And you need observation, not because the epinephrine itself is dangerous.
Okay, that makes sense. So that sounds like a great option, and all 3 of them sound pretty easy to use, which is great. But is there anything new on the market that I guess people don't know as much about and don't know the pros about that you can share with us?
They sound easy to use until you have a squirmy child and or you yourself are deathly afraid of needles. So a lot of parents, even though they know in their heads, that I would rather them when in doubt give it, they're not going to hurt their kid, like this is all good and they should do it, still struggle to give it. Or a lot of teens, etc., even fully grown people are afraid to inject themselves because they're afraid of needles. So we just got on the market this guy. So, there's no needle here. This is intranasal epinephrine. Unfortunately, so far, it's only available for adults. So this is not something that you can yet get for your kids. You have to be 30 kilos. Sorry, I know we're in America, but kilos for kids. So it's about 50, 60 pounds. So you have weight to you, which is an adult, usually size, or an older teenager, certainly, but not like an 8-year-old.
Yeah.
A larger 8-year-old. But the way you use this is super neat. So you just put these. I'm a righty, so it's in my right hand. If you were a lefty, you could use it in your left hand. You put your fingers here, and then this on the plunger, you would put it in your nose. Obviously, I'm not going to do that because gross. And then you just shoot up, and that's it. You don't have to sniff, nothing, and then you are done.
Wow.
So a lot of people are really excited about this guy. It just came on the market this year.
Oh, wow.
Or at
Very good.
all.
Are there any cons to using that?
So what I tell everyone who's interested in it is the approval came not based on like studying patients who were in the middle of a reaction and used it and, oh, they did great. It's actually what we call pharmacologic data, which means they gave it to normal, healthy people not in a reaction. And then they took their blood later, like at different time points, to see how quickly and what concentration the epinephrine would reach. So how quickly it was absorbed and that it's getting into your system. And then comparing that to what you get if you do the same thing with one of these, which is an injection or a syringe, and what we know generally concentration-wise works. There is a little bit of patient data available from Japan, because Japan required them to provide some patient information before they would approve it for use. So there's a very small case series from there. But in general, we don't have a ton of data on that yet. Sometimes I'll prescribe it together, and that way if it fails, you can always have one of these. And the company is actually being very aggressively asking anyone who uses it and has a reaction to report in, because they do want that data, and they will collect it and report it. So that's just something to be aware of there. There are some people for whom this is not okay. So if you have any sort of nose anatomy issue, like your nose is differently shaped, then you have to see the ear, nose, and throat doctor for that, or you have polyps in your nose and you have to see the ear, nose, and throat doctor, you can't use this because it's going to block the absorption. And if you use a lot of nasal spray medications, you should know that like for a week or two after using this, you may not be able to use those medications because the absorption will be different. It will be like vastly increased because of this guy. So there's just some things you have to.
Wait, I lost you. I didn't hear you at the end. Okay, we're good. I hear you, I think. Wait. Talk one second.
Can you hear me?
Okay, good.
Okay.
Okay, sounds really cool. Hopefully in the next year or so, people will start to use it and see if it works.
Trying to get it approved for pediatrics. So they're working with the FDA on that. As soon as we have it, we will generally start prescribing it. And you will probably have to fight a tiny bit with your insurance company because it's new. So we tend to have to do a prior auth, etc. But I just asked my nurses today in advance of this phone call, because they fill out all my prior auths for me, and they said pretty well for the few that we've written. They have been fairly successful in getting it approved, which obviously brings down the price a lot.
That's great. That's great to hear. Okay, and just circling back before, I know most moms probably don't have these sprays since it's not available to kids yet, but when circling back to Epi-Pens, do you have any specific feelings towards who should be holding the Epi-Pen? Should the teacher have it? Should the nurses have it? Should the child have it in their backpack for the younger kids, I guess?
So the first thing is to realize that insurance companies are not intelligent. They do not realize that children are not adults. So an adult can self-carry their medication and just keep it with them at all times. Most children are not capable of doing that. And children are in at least two places. They're home and they're at school. Some children are even in more places if they spend time with their grandparents, or if their parents live in different locations, for instance. Or you may have a house in Dale and a house here, and you go up there on the weekend, right? And what if you forget to bring it, etc. But certainly home and school, right? So depending on the age of the child, they're going to have to need it in different places. So the first thing to know is I always try and write for 2 packs, because you're not supposed to separate the 2 pens, even though a lot of people do, including school nurses, and I keep telling them not to, but they keep doing it. You're supposed to have the 2 together, because if the first one either doesn't fire correctly, or if it works but the symptoms come back really quickly, you're supposed to use the second one. It's there as your fail-safe, not because they thought you were going to have 2 different reactions. Yeah, that's why they're together. You're actually supposed to keep them back together.
Mm-hmm.
So if the child is very small and they're just with their mother, etc., or with a babysitter, great, you can put in their diaper bag, you can take it with them. Except this guy is the only one that's been shown to survive like extremes of temperature. So you don't want to like leave them in the car by accident or have them like freeze or so, because we don't know if they'll work afterwards. But then when we get to school age children, we have a real question. We're going to need at least two.
Okay.
For home, but the insurance company might only let you fill one box. I put refills on it because after a certain number of days, you can then just refill it. So even if you didn't use it, just refill it. And that's how we get around their ridiculousness. But then once you have them, what do we do with them? So for a really little kid, like early childhood, etc., obviously they are not going to be able to self-administer or even like recognize their allergens or their symptoms. So we're going to need an adult. And at school, for the set that at school, that could be the school nurse, that could be the teacher. Now, the tricky thing about it being with the school nurse is where is the school nurse in relation to the child? So sometimes they're in a different building or like floors away. Sometimes they're not there the entire day and maybe their office is locked or nobody else knows where their system is. And so someone is running in there looking for an Epi-Pen and they've no in the middle of your action. So I don't love that. So you really want to work with your school to make sure that that's not the situation. But I also encourage all teachers who are interested it's really easy, as you saw, to learn how to use these. So a lot of teachers actually are also willing to just know how to administer and know where it's kept, either if it's kept in the backpack or in the classroom, or they will know exactly where it is in the nurse's office so that they can run and get it and retrieve it like as needed versus someone like, oh, and where is the nurse? And she's out on the battlefield with her ankle and nobody knows where they are. Older kids, it just really depends on your kid and their maturity level. I've seen kids really young be able to do it, and I've seen teenagers not be able to do this. Can often be approved for self-carry and self-administration, so they should not be forced to give in their EpiPen to the nurse. They actually can keep it in their own backpack if we approve them for that. So in that scenario, the child has to be able to like actually articulate what their allergy is and what kind of symptoms they could have that would require them to use it. And then they can show you with one of these trainers how to administer it. I can tell you one of my kids was able to use a trainer like better than most grown-ups when she was 8 years old. So that's her. She's really like mature and that kind of thing. One of my other kids may not be able to use it even when she's a grown-up. So it's very child dependent. You have to have relationship with your allergist, or the school nurse will sometimes administer a test too. Some of them have that. But for the kids who can self-administer it, they can carry it themselves, and that way it's always with them. But you have to make sure the other piece of information, they might know everything that they're doing, but that kid that always leaves their backpack in school?
Yes.
Yeah. Because then you're not going to have it, or at least make sure you have one at home and then that one can be the one in school. Yeah. So you got to know your kid and like be honest with us, because we can like check about, right, can they go through the steps, but we also have to be honest about, are they deathly afraid of needles? Are they going to forget their EpiPen places, etc.?
Right. Yeah, that makes a lot of sense. Okay, so sounds like we really covered mostly all of the treatments. I just wanted to touch a little bit about, I know a lot of young moms start to give their babies foods around 5 or 6 months, and they have a lot of fears. How do I know they're going to have a reaction? What kind of reaction are they going to get? If they have a reaction, when should I be concerned? So I guess what would be your little snippet to a new mom starting out foods? How would you tell them what should they look out for? How should they start the foods, the specific allergens, and when shouldn't they start those specific allergen foods?
So this is a really hot topic. It gets a lot of like press and like Wall Street Journal or New York Times, etc. But like in 2 words, like be brave. Okay. We really over medicalized the feeding of children over, like 50, 60 years of medical science, telling people, oh, wait until they're 1, wait until there's that. And then we realized that we were actually not doing the right thing. The data is really the best for one specific food, that's peanuts, because it was noticed that children in Israel who all eat bamba were generally not having peanut allergy. So then they went to a different and British children. They tried giving them the bamba, and so they specifically did that in high-risk children. Wow. So that would be children who have really bad eczema or children who had an allergy to eggs, and they found that it was very protective for those children. in the general population, where your child doesn't have eczema, they don't have like any other food reaction, etc., I generally say be brave. As soon as your pediatrician tells you that the child is developmentally ready, because they have to be able to sit up and, chew and not choke and all of that. Whenever the pediatrician tells you they're developmentally ready to start eating foods, you can give them everything but honey, essentially. And honey is not for allergy reasons, it's for botulism. Their stomach acid needs to develop more. But you can give them everything. And so I say what you eat, your child should eat, so long as it's not in a choking hazard form. So you may have to mush it, grind it, powder it, whatever, blender it, whatever you got to do to make it not dangerous. Like you can't give a baby a whole peanut, obviously. And you have to thin out the peanut butter, but otherwise you should give it. And those high risk children, so those children who have kind of bad eczema that's requiring maybe topical steroids or a visit to the dermatologist, not just like eczema that needs some moisturizer. That's okay. We'll leave those guys alone. Everyone is allowed to do that. But so people are needing steroids and dermatology visits, or if you started feeding them and you fed them eggs and they had like a big reaction to eggs, they should see me anyway because they're clearly allergic to eggs, but we should deal with this too. We want to give it to them early, but we realize that they're at a higher risk for having a reaction. So we tell you to bring them into us generally sometime between 4 and 6 months. I prefer a little bit earlier. Like I prefer the 4 or 5 months. That way, by the time they're 6 months and you're feeding them, it's been taken care of. And we'll put a little scratch test on them for you. And then based on that, we'll say either go ahead, give it at home. Oh my gosh, it's already happened. They're already allergic. That's pretty rare. Or not infrequently, they'll be in this in-between zone and we'll say, okay, here's what we're going to do. You're going to bring them in and we're going to do that food challenge. Or I'm going to try and get them to eat the peanut butter in front of me. And that way the mother does not have to be so nervous having to do it at home. She'll do it with me the first time. And then when it goes well, they continue at home. And this is like a really powerful thing, but it is also the only time that I would place food allergy testing without a history of a reaction. A lot of people will come to be like, can you just test them because I'm nervous? Actually, it's not recommended. You get a lot of false positives and we will drive you crazy. So we will harm you more than help you. Your kid's going to start losing weight because we've taken away every food. Then you're going to have to come in for 50 food challenges to clarify. You don't ask for trouble. You don't want this. So without any sort of likelihood before we place the test is actually really not great. We get a lot of false positives and then we have to do a lot of food challenges to clear them. So we're generally only doing allergy testing. And this is something that, your general pediatrician, they used to send for some reason allergy testing on everyone when they were like a year old. They should not do this. We don't want them to, because then they send them to us and we're like, it's never should have been done.
Yeah.
But it's just a little bit old school and then we have to undo it. But when you have a reaction, then we'll decide what to do. But otherwise, we get a lot of false positives. So we don't generally recommend that. This is the one and only case. And it's not because we're looking to take away the food. We're looking for it to be negative so that we give you the food. And honestly, we're pretty aggressive about if it is positive, just bringing them in and challenging it in front of us because you want to get it into them pretty early.
That makes sense. So let's say I have a cousin or somebody in my family who has an allergy and now I'm super nervous. Is there a way that I could prevent that allergy in my child? Is there any tips of what I can do or mother can do, father can do to kind of prevent that allergy?
Yeah. So the first thing I would say is we have driven pregnant and breastfeeding women crazy by making them eat nuts, making them not eat nuts. It doesn't work. Okay. So
good to know.
To deal with, please just take care of yourself and eat whatever you can keep down without throwing up. Okay. It's not going to affect your kid one way or the other. In terms of, there's a choice, right? After you have the baby in the hospital, do you want to give formula? Do you want to nurse? Again, the first priority is to take care of the mother and her health, because you're not going to be a good parent to your kid if you're going crazy trying to force something that's not happening naturally. So I can work with you whether you're nursing or whether you're on formula. It's all the same to me. There is some slight benefit that has been shown to nursing. You don't have to change the mom's diet at all. I don't generally do that unless we have symptoms. But there is a theory that you will have less allergy for that. That being said, I have seen women who have exclusively nursed their children until they were 1 year old and the child still had food allergies. So I don't want anyone blaming themselves or like unnecessary guilt being placed on people for this reason. But giving the food earlier does tend to be helpful. So you shouldn't be afraid. Giving the food earlier is helpful. And if you have a reaction, we'll deal with it. not the end of the world.
So just really starting.
Common right now. So I say what you eat, they should eat.
Okay. But
No,
do you think that starting, let's say at 6 months rather than at a year, like starting those specific allergens helps?
for peanut, we have good data that it does. For the other foods, it's not as clear. So there are some suggestions that it will help for certain foods, like maybe eggs, etc. But it's not as clear. So again, I wouldn't drive anyone, nuts, making them go to 500 stores to try and, do this if they can't find the food, etc. But if it's in your house, I see no reason not to give it.
Okay, sounds like a good plan. So moms out there, if you ever have questions or ever need some tips on how to start feeding your baby, you could always hit up Dr. Samstein. I guess any other tips for a mom who then does have a child diagnosed with an allergy? Any tips for school, birthday parties, life?
Yeah, so the first thing is like to know you're not alone. So back when I was young, like there was nobody with a food allergy except my sister. And like we didn't even have Epi-Pens, okay, for her. Like nobody knew what was flying. This was like so far in. And now like, the class is having a party and people are on the WhatsApp being like, what are the allergies in the class? So it's the best time to have an allergy, but also know that you're in this. It's nothing that you did. You didn't cause this. Like there's a lot of guilt that's going on about it. No, like let's let the guilt go and move forward. And then in terms of making sure that your child still feels healthy, happy, and included, one, when you're going to a birthday party, you do want to talk, especially the little guys, you do want to talk to the other parent. Just to make sure like, oh, what's going to be there? And then I often, when, the kids are really little, sometimes you'll send them with their own like, complimentary food. So for instance, if everybody's going to eat pizza and there's no real like plan for what to do to your kid, and other parents are more accommodating than others, but if you have a dairy-free pizza that your kid likes, you could send that with, and your kid is not like looking around at everybody else eating, right? Or if you're not sure about the cake, because people really try, but if they don't have allergies, they might have not saved the label or something, and you want to read it right before you give it. But if you have your own cupcake, like, your kid can still have something. So you do have to plan a little bit ahead about that. When you go to restaurants, you have to be really clear with them. In the US, it tends to be pretty decent. In other countries, they have no idea what you're talking about. So you have to be, again, really clear. And I will usually Google Translate and or like have down on a piece of paper, in that language, what your kid can eat, because they might not understand you. If it's something like dairy, I would have the word for dairy, butter, milk,
Yeah.
all of those, because you'll say dairy and they'll be like, yeah, milk, and then it's like a stick of butter on those noodles. So you do want to
Be
be
very
a little bit
clear.
but you do not want to bubble your child and not let them go out, not let them be with other people, etc. This is really harmful. We do not want the children to feel like they're left out. They generally don't need to eat on a separate table. If anything, that often leads, at least in public school settings, to increased bullying or separation of the child and anxiety for the child. I think in our community, we have less of the food bullying issue because everyone around health is a little bit more conscious. But for instance, kids in public school, if they're sitting at a separate table, will often then be bullied about their food allergy and or with their offending food, which is horrific. But kids don't have developed frontal lobes of but you just really want to work with the school and the other parents to make sure that your kid is still included in a happy and friendly kind of a way. We do not generally recommend restricting the other children in the class. It is a very rare scenario that a child has something like airborne, where they can't even be in the room with it. That's pretty rare. And even when that happens, it's generally in a situation where, like, let's say you're on an airplane and the air is regulated, and some genius decides to heat nuts in first class, like so that they're literally heating mixed nuts to serve to the first class passengers. Yeah, that could be an issue. But like one kid eating a peanut butter sandwich and the other kid your kid is just not, is okay. The teachers just have to, there's no food sharing. And when they're young and when they're messy, they have to make sure they clean it.
Yeah.
So you have to clean. And I ask the parents whose kids don't have food allergy to please be considerate and not like take their kid to the playground waving around a peanut butter
Right.
over every swings and every one. Again, gross just in general. Nobody wants to touch that and then be covered in your kid's peanut. But, another kid could actually have a significant health issue because they don't understand. They put that in their
Yes,
mouth.
that makes sense.
So people don't generally realize that. And I'm not saying you can't feed your kid when you're outside, but like maybe have them sit down
Mhm.
until a couple bites.
Finish
And
your sandwich and then play.
exactly. Hazard to have them eating a sandwich on the slide. Like they could choke on the way down. Peanut butter is really thick. So
Fair enough.
just be careful.
Okay, sounds good. Sounds like a lot of good tips. I hope all the moms out there and parents and teachers and whoever's on here um, enjoyed and heard these tips. So we're going to just open the floor up to anyone who has questions. I see 2 questions here, so we'll start with those. And if you have any others, please type them into the question box. So the first question is, what are your thoughts about using Xolair? Xolair, is that how you say it?
Xolair. Yeah. So Xolair is the brand name for a medication called omalizumab. And that's a generic name for it. But that being said, there is only the one. You can't like find a generic yet. It's still under patent. So, the exposure therapy treatment that we talked about a while ago, some kids don't make it through that because they keep reacting to their allergen, even at very low doses. Now, incidentally, we sort of know because the first indication for omalizumab was unexplained hives. Interestingly enough, people with unexplained hives don't tend to have allergic issues other than their unexplained hives. They don't tend to be allergic or asthmatic, so we'll put them aside. But then it was found that medication was also really good for asthma. So we started giving it to severe asthmatics, and it really keeps them out of the ICU, et cetera, and from needing a lot of oral steroids, which is great because we don't love to give kids a lot of steroids or grown people a lot of steroids, frankly. It's not like the world's most benign medication. So we found that those shots were helping them with their asthma. But then there was an interesting thing noted, and again, it's mostly in other countries. So in, let's say, Italy, for instance, people with food allergy were having tons of accidental exposures because it was harder to avoid it because labeling wasn't as clear, people aren't as careful, not as aware of food allergy. And what they found was lots of people with asthma also have food allergies. These things do tend to go together. The patients who were on the omalizumab or the Xolair were having significantly less accidental reactions per year than their compatriots who were not, and they're living in the same country, et cetera. So it wasn't like, oh, they're just being more careful. So, this got people thinking maybe this was actually helping also for their food allergy. So the company that manufactures that medication thought, oh, well, maybe if we give them this shot, it'll help them make it through the exposure therapy. So they set up a huge trial to determine that. Now, that trial is still ongoing, but the control group, so the 2 groups were going to be like people just getting, the exposure therapy and people getting the shot plus the exposure therapy to see if they had an easier time, etc. The control group was supposed to be just giving the shot just to see what it does on its own. And that was just the first 60 patients were just going to get the shot and then see if they tolerated their food. A lot of them did. So while they were on the shot, a good 70%. So that's not 100%. It's a good 70% of them tolerated their food. Now, if they were polyfood allergic, the more foods you added, the worse it got. So they might tolerate one of their foods and not the other foods. But in general, it still did pretty good and way better than anything else that we have because everything else that we have is just treating your reactions. So obviously the company got really excited. And so while the rest of their trial is still ongoing and we might get data released from it soon, they quickly ran for an indication to the FDA to get it approved for it, and it is approved for it. Now, there's just a couple here. Again, it is not a cure. So it is a treatment that hopefully prevents you from having really bad reactions if you eat your food, but you're not supposed to eat your food. You're supposed to continue to be avoiding it. So it's more for accidental exposure to make you bite proof. Like if you accidentally eat it, you shouldn't have a big reaction. You still have to carry your Epi-Pen. And you have to give yourself this shot indefinitely for, if you're really little, 4 weeks, but then as you gain more weight, 2 weeks. So every 2 weeks, giving your kid a shot for this, maybe yes, maybe no benefit. So for most people, they're not loving that.
Mm-hmm.
So I'm only using it in very specific situations. That being said, my colleagues who do the exposure therapy are using it off label all the time now to help people make it through the exposure therapy, because then they just stop the medication at the end of the exposure therapy and they continue just eating the food, which most people can deal with eating a food. every day versus giving them a shot every 2 weeks. So it is a useful medication. It's better than anything else we've had for in years, but it's really for a very select population. I'm not like recommending it across the board because for most people, it's not going to work so great. If you happen to also have asthma, or unexplained hives, it'll hit both things at once. And then I'm like, all systems go. Obviously, I do not want people to have really bad asthma that's untreated. But you just have to explain to them, like, oh, if you stop the medication, your food allergies is present. Please be more careful.
Yeah, that makes sense. Okay. Okay, thank you. That's a good, nice, extensive answer. Another question. Sorry,
Coming this
what'd you say?
we might get more information even coming this year. They tend to release the data from their trials when we have our big allergy conferences, which happen in February and March. So last year it was February. So I'm hoping they might have more data this year. If not, it'll be February next year.
Okay, so fingers crossed. We'll have
Yeah.
to wait and see. Okay, so we have a bunch of questions here. Let's just go in order. What does a true reaction look like to a first food allergen?
So it's a little bit interesting. Sometimes it's the first time you eat the food, but it's not always the first time you eat the food. It could be the second or third time. It's generally not like the 8th or 10th time. The exception being shellfish. Shellfish is a bizarre food. That being said, most of us are not dealing with shellfish. So, maybe there's a reason why we avoid shellfish because like grown adults who've been eating it their whole life can have it. But for a regular non-shellfish food, it'll usually be within the first few times that you eat the food. And you can have a range of things being the first reaction. So most first reactions are generally mild and within an hour or two of eating the food, but usually way, way sooner. So often even while eating the food or, 20, 30 minutes later, you might see them start to get a little fussy. You might see a rash. Sometimes they're happy as clams, but you're like, what is going on your skin? So you might see a rash, you might see some significant vomiting or diarrhea, and you might hear some wheezing noises, etc. Any of those things can happen. So have people anaphylaxed on their first time having a reaction? Yes, but it's more common for your first reaction actually to not be as severe as maybe sometimes your later reactions. So you definitely want to be looking out for those things when you're giving foods for the first time. The other kind of reaction that I spoke about, the Epi-Pens, is different. It's more rare, but just like to spread awareness about it. This will be, and this sometimes takes several exposures, one to get a reaction, so it could even be on the 8th time you give the food, but also sometimes it takes a few times of it happening for you to realize it was the food because it happens sometimes 4 to 6 hours later. It is the worst vomiting you have ever seen in your life, okay? It is so much vomiting, and you're really tired. And sometimes it's also accompanied by diarrhea.
Okay, good to know. Okay, simple question here. What is the name of the non-drowsy Benadryl?
That's called Zyrtec or cetirizine. There is a children's dose. Just if you want to buy it for your house, just ask your pediatrician at your next well child check to talk to you about it and what your kid's dose is based on their age. It's age-based dosing, not weight-based dosing. And if you're on any other medications, obviously you have to go over it with them. So there's certain medications that any of these, actually, including Benadryl, will interact with. So if you have like seizure medications or things like that, you have to talk to your pediatrician or your neurologist first, because there are actually these drug interactions that you have to be really cautious about. It's generally over the counter. It's pretty harmless. But if I have a kid who's epileptic and on seizure medications, I always talk to their neurologist before decide which will be their first line medication, because it's all different considerations we have to take into account.
Good to know. Okay, next question. Contact rash with babies. How to know if it's a contact or not, and how do you continue exposure?
Yeah, so contact rash is an interesting thing. A lot of babies have very sensitive skin, as the parents among us will have realized. And when the food touches them, they'll get a rash where it touches, but it will not happen anywhere else. So that's the hallmark of that. Nothing else happens. There's no other symptoms. It's just that rash, and it's only where the food touched. So if your child was clothed and they didn't spill it all over themselves and they have a rash on their abdomen or their legs, okay, that's not really a contact rash. But if it's only around their mouth or their cheeks, or if they were naked and a mess, as many kids are, wherever it touched, there was a rash, but not anywhere else, it's generally considered really harmless, and we'll feed through that. What I always say is if you're nervous about it, feel free to come in and have an appointment and we'll talk about it. Take about like 1 million pictures if you can. This has really, really helped. The availability of like iPhones and pictures has really helped us be so much more accurate and avoid so many unnecessary food challenges. Because if we can see what your kid looked like at that time, you know, and then you're not like, didn't it? Because it's really hard to remember these things when you're nervous. It's
Mm-hmm.
just, and we'll talk about it. And then if that happens in general, we feed right through it, but you want to avoid the contact as much as you can just to help with the rash, although they're usually really quite happy and it doesn't bother them. So sometimes I'll put Vaseline or a little bit of moisturizer on their face before I feed them as a barrier so it doesn't touch directly. You're trying to get as much of it into their mouth and not in their body, but okay, that's a bit of a losing battle. When you have a toddler, and then you're wiping it off pretty quickly so that it doesn't sit on there because you get big, you know, more longer it sits on their skin.
Okay, that makes sense also. Okay, great. So let's see where we are. Okay. Can a child grow out of a dairy allergy? Wait, sorry, I lost it.
Most children will grow
But
out of their dairy allergy.
still react with hives or rash on their face.
So the great news about dairy allergy is the majority of children will outgrow it. But it's majority. It's not all of the children, but the majority of them will outgrow it by the time they're even age 3. But even some of them a little bit later. Like, don't lose hope. If it's after age 3 and they still have it, they can still outgrow it later. So that is a great thing. And we do a food challenge and we clear them in the office, and we're always super excited about that when it happens. But I wouldn't tend to expect them to have hiving after eating the food. They could maybe have some contact irritation if they have super sensitive skin, and we would have to talk about that. But that's why we usually clear them with a food challenge. So we're going to watch them eat it, and then we're going to decide together, right? Because they're going to do it in my office. They're going to do it. So if they get it all over themselves and they have a rash, like just where it touched, I generally am okay with it. But this is in conjunction with the parents. We're both looking together. We're making our decision, plus my allergy nurse. So you have like numerous people staring at this hive. And we make that decision together. But yeah, if you're going to choose an allergen, dairy and egg are great because most children outgrow them. So those are my allergens of choice, for sure. As opposed to peanut, much less outgrow it, but about a quarter will.
Yeah, I mean, I would prefer no allergies at all, but yes. Okay, this one's a bit specific, but someone asked if their son has a blood level number of 20 for sesame, does it mean he'll for sure have an anaphylactic reaction? He's a bit older now and he hasn't had an anaphylactic reaction since age 8. Can he be less careful or how should he proceed?
Yeah. So I'm going to broaden the question a little bit so it's more useful for everyone listening, because you asked about several things that are actually really important, I think, for a lot of people to understand, and that's the interpretation of the testing. So whether it's blood or whether it's on your skin, in the blood, they spit you out a number. And the lab will label it high, anything above 0.35, just so you know. And then on the skin, we actually like measure the hive with a ruler. And so the number we're giving you is millimeters for the wheal, and then additional millimeters for the redness, which is called erythema. So the part that's raised and then the redness. So 2 different numbers that are measured. The number that I'm concerned about is different for every single food. So for instance, a cashew, I will have a much more concern about, you know, a low number than something like gluten, which gives everybody high numbers and is very to deal with. So that is, you know, a thing to know in and of itself. The number has to be interpreted by someone qualified and in the context of the patient's history. So they need to know about the previous reactions, what's been going on, etc. All of that plays into the interpretation of the number. And the way we set those cutoffs is generally by looking at hundreds or thousands, ideally, of children who's had the testing and then subsequently had food challenges and comparing their numbers and being like, oh, okay, if you have this number, you have a 50% chance of passing a food challenge. That also means you have a 50% chance of failing, but I like to look on the positive side. We're pretty aggressive. I will challenge at that point, but it's very food specific. You also asked about sesame. Sesame is an up and comer. It's number 9 on the major allergens. So we are still learning more and more about it. Sesame blood testing is a little bit unreliable. So you have to really interpret it within the context of the patient, the history and the previous testing that you've done with them to compare, like to the baseline, etc. And sometimes you can even get sesame component testing. We can't always get it, but occasionally we can, and that will help us too. And or you may need also a scratch test and think about them all together. Now, the other part of your question was based on this number, can I tell if my child will have an anaphylaxis? No, And that is different. That is the same for every single food, every single test, every single number. I don't care if you would have, as long as your number was not a number that I think is allergic. The answer is no, I cannot tell based on your number if your child will have anaphylaxis. I wish. It is the largest wish of most of us, other than a cure, obviously.
Yeah.
Or a reason why everyone has this right now, because we don't know. But what the allergy testing number tells you is likely allergic or likely not allergic. It does not tell you what the reaction will be when you have it.
Yeah.
Nothing what the reaction will be when you have it. So if you had a large reaction in the past, you are more likely to have one again. But if you've only had rash or mild reactions in the past, that does not mean that your next reaction will be mild. It may be anaphylaxis. So you have to take the precautions as if you're have one, even if you're not. And the number's not going to tell you what the reaction is. That's why when I'm deciding on a food challenge, I'm always doing it in my office, because if I think there's a chance of you reacting, I don't know what the reaction is going to be. I need you to do that in my office so I can treat you immediately, and I'm right across the street from an ICU.
Fair points.
I don't tend to use terms like mild or severe allergy. I think that's really misleading because we don't know.
Yeah.
Right? And I don't want people to be blasé about your kid. I want them to take it seriously. Yeah. So I wish we had it. The only thing that has been shown to have promise, unfortunately, is only a research test, because you have to draw the blood and immediately process it. So you have to be sitting in someone's laboratory, which is not really very viable. But if someone could fix that, it would be an extremely useful tool.
Yeah, for sure. Okay, another person asked, what are your thoughts on OIT?
So OIT is the exposure therapy that we were talking about. It's called oral immunotherapy. If you think back to the other kinds of things that I treat, for instance, environmental allergy, you might have heard, or even yourself gotten allergy shots in your life. So that's for things like pollens, cats, dogs, etc. People think that traditional doctors are anti-homeopathy. Allergists are the original homeopathists, okay? We have been doing this from the beginning of allergists existing. What we do is we were taking people's allergens, right, and diluting them way down, because we can't just inject you with them. That would be not a good idea. And we give them small amounts, and then each week we give them an additional shot, and it goes up. And we've known for a while now that really works for people's environmental allergies. So there was a question of, could we do a similar thing for food? Not with shots, though. You have to eat it.
Okay.
We're talking about with the exposure therapy, those extensive 3-hour visits every 2 weeks, and then having to take it at night. And if you get sick, having to change the dose, etc. So it's a very involved process. And what I generally say is it is an option, but it is not a requirement, because it really has to work for your life. You have to be able to do it. There's also restrictions about when you eat your food at home. You can't be running around. You can't take a hot shower. So if your kid is in 12 after school sports, this might not be the thing for you. So you really, the whole family has to be able to participate in it. Or I also work specifically with an allergy psychologist. So some of the kids are deathly afraid of eating their food, and they might have to do a few sessions with her before they're ready. You have to be conscious of that. The kid has to want it too. It does tend to work better the younger you are. But now that we have the omalizumab, when we get that data, because we don't have it yet, we may be able to do this even in adults. But right now, we really are preferring to do it in children. And the youngest, the better. I don't myself perform it. That's not because I don't think it's good. It's because I don't have capacity. So you have to be doing a food challenge on your patients every 2 weeks, right? That would require me to do many food challenges a day. So I would need a fleet of nurses and dedicated rooms just for that. I'm in a multi-specialty practice because I'm in a large academic center. So I share my space with also the endocrine doctor and the gastroenterologist, et cetera. So I don't have the space or the staff. We're talking about maybe one day doing it, but as of yet, that's why I don't specifically offer it, but there are practices that do. You want to talk to them about it because it's not standard. So everyone has their own protocol. You want to ask them all their questions. It also might determine you're not a candidate. If your reactions have been so bad, they're not just going to do this, right? They have to do it safely. So you really want to know what you're getting into and make sure that it works for both your kid. You don't torture your child. So it has to be working for your kid. They have to want it. And also for your life, you have to be able to do this every 2 weeks, and it's not going to work if you're not going to consistently give them the dose at home. Don't be shocked when then your kid has a reaction in the allergist office if you can't give it at home. Just be honest with yourself, and it's okay if you can't do it. It's fine.
They'll be okay. They'll figure it out. But it's a good option for people to have.
them of this option. It's for some people and it's not for others.
Mhm.
So it's a really unique and individual choice to do it.
Okay, so some on the same topic, so I'm just gonna throw this question out. It's specific for baked eggs. So they asked when they graduate, do they need like from, I guess, baked eggs? Do they need to eat baked eggs every day, or could they move on
Yeah.
to exposure therapy for cooked eggs and then just freely eat baked eggs?
Yeah. In a couple of foods, there's different forms of the food. Specifically, it comes up for egg and for dairy. There's scrambled eggs and whole milk, and then there's eggs in like a cake or a muffin. So that's been extensively heated, or dairy that's been baked, right, in an oven. I'm not talking about butter on your stovetop. It's like in a baked good in an oven. You made it with butter, for instance, or even milk.
Okay.
Is what you're allergic to in food is proteins. Proteins are made of essentially little building blocks. You can think of them like, I'm not going to say Legos because Legos are really rigid, maybe like Kinex, called amino acids. And then when those things are in a line, the Kinex, because Kinex are flexy, then some of them are attracted to the others, et cetera. So they form this big old ball of protein. Sometimes you're allergic to the thing that's in a line, right? So even if I break up the ball, that line is still there, and you're still going to be allergic to the baked thing, unfortunately. But sometimes you're allergic only to these two things being together, and when I bake it, that is destroyed because it's now all in a line instead of in the ball. And those are the kids who can eat baked. We know that when we get them through the baked, so we do a food challenge for baked and we see they tolerate that, but they will still react to, let's say, a scrambled, right? We have seen, because these are also two foods that are commonly outgrown, regularly eating your baked food speeds up the process of outgrowing your other food. So you have to work with your allergist. They're going to tell you how many times a week minimum they want you to give it, and then when they want to test again for the other food. When they test again for the other food, they're going to talk about if you're ready to do the food challenge for the next food. So it's a second food challenge. We wouldn't usually just tell you to eat it at home in most scenarios. But again, each patient is individual. So this is just as a general way how it usually goes, is then we do the food challenge for the next food if the child is ready.
Okay, very interesting. Okay.
The
And then
something is, the less allergenic it tends to be. I know people don't love processed foods, neither do I, but as it happens, all the protein in there, that's probably why it's not so good for you.
yeah.
Everything, the over processing.
Okay, we're going to wrap up with one last question. Someone just wanted to know if you think that a dairy allergy is a specific gene, or do you find it to be genetic?
Yeah, so in terms of identifying a specific gene, we have never found a specific gene that causes any food allergy. Doesn't a genetic component, means it probably has many different factors playing into it. So there could be genetic factors, there could be environmental factors. There may even be factors about the actual food that we eat changing as the weather conditions in which they grow are changing, like different carbon dioxide, et cetera, might be changing the proteins in the foods. So we generally consider it to be many different factors playing in. So both genetic and environmental. Actually, the highest risk for having a food allergy is if your parents have allergic rhinitis, which is just like seasonal allergies. That's probably because so many people just have seasonal allergies. So if you are allergic to food, that does not necessarily mean that your child will be allergic to food, but they are more likely to be what we call atopic. So they might have eczema, they might have asthma, they might have, who knows. I also have kids showing up in their office and their parents have none of this, right? None of this. And they're like, where did it come from? And like, we can find like great Aunt Sylvie or something, but in general, no. We and it just happens. And then sometimes the parents are ragingly allergic and their kid is like, what's wrong with you people? And scarfing down peanuts and a pizza in the visit. And the parents are like, stay away from me. So we don't know. We really don't know. It certainly does seem to run in families having allergic issues. One kid has asthma, one kid is allergic to peanuts, one kid can't eat, cashews. But we also just have one-offs. Sometimes family of 10 and only one kid has allergy.
Yeah. Okay. So we don't know yet, and hopefully with all this research and all these new things coming out in the next years, hopefully we'll get some more answers. I just wanted to thank you. It was really informative, really interesting. I hope everyone watching enjoyed. If you have any questions, you can always come to Dr. Samstein's office. And again, just a thanks to SBH Medical. If anyone needs any help finding doctors or with anything specific of their medical needs, feel free to reach out. We're here to help the community and help you with all of your needs. And thanks again.
Thank you for me. These are actually really great questions from the audience. So I think we have a very educated audience here.
Thanks again. Bye, guys.